ARDS stands for Acute Respiratory Distress Syndrome. It is characterized by acute onset of severe dyspnea with bilateral chest infiltrates plus patient demonstrating hypoxemia. Can occur with both medical as well as surgical conditions. The reasons, the etiologies will be dealt in the next slide. In direct as well as indirect lung injuries. Causes for direct lung injury that can predispose to ARDS are pneumonia. Pneumonia is the most common cause for direct lung injury causing ARDS. Apart from this, aspiration of gastric contents, pulmonary contusion, near drowning, toxic inhalational injury. These are the direct lung injury causes that results in ARDS. Coming to the indirect lung injuries, sepsis accounts for 40 to 60% of the cases, and severe trauma like multiple bone fractures, flail chest, head trauma, burns, multiple transfusions, pancreatitis, all these can predispose to ARDS. Remember, pneumonia and sepsis are the most common causes for ARDS. There are certain risk factors which gives a worse prognosis to patients suffering from ARDS. That is, when there is more than one predisposing factor operating in the same patient, or when the patient's age is more. That too, when the patient's age is more than 75, he is at having high risk of mortality. And metabolic acidosis, pancreatitis, and those who are chronic alcoholic and who have high Apache score of more than 16. All these are considered as risk factors. And coming to the clinical course, this disease is characterized by three phases, that is exudative phase, proliferative phase, and fibrotic phase. This is the first stage, the second stage, and the third stage. First stage lasts for 1 week. The second stage lasts for the next 2 weeks. Then your fibrotic phase comes into action. The alveolar edema predominates in the dependent portion of the lungs, that is in the basal parts. So as a result, there is shunting of the blood which results in hypoxemia. Apart from this, microcirculation of the ventilated parts of the lung can result in increase in the dead space, which can result in hypercapnia also. Coming to the exudative phase, here the endothelium and the alveolar epithelium gets damaged. As a result, the alveolar capillary barrier is disrupted, which leads to proteinaceous fluid accumulation in the alveolus. Then the neutrophils gets recruited and inflammation ensues, which results in lung injury. The aggregates of plasma proteins, dysfunctional surfactant, and debris forms hyaline whorls in the alveoli. As we said earlier, this exudative phase occurs during the first 7 days, and X-ray will show infiltrates in more than 3/4 of the lung fields. And when patient has cardiomegaly, pleural effusion, these are points against ARDS, because the differential diagnosis for ARDS are cardiogenic pulmonary edema, alveolar hemorrhage, acute interstitial pneumonia, and hypersensitive pneumonitis, of which cardiogenic pulmonary edema can be easily ruled out when the patient has cardiomegaly and pleural effusion. If there is any doubt, you can go for an echo to rule out the cardiovascular causes. Proliferative phase, this occurs during the next 2 weeks, that is from the 7th to the 21st day. It is 7th to 21st day. Most patients will be weaned by this time, but some enters the fibrotic phase. Some develops pulmonary fibrosis also. Here, lymphocyte predominates in the alveoli, whereas neutrophils will be the predominant cell in exudative phase. Type 2 pneumocytes proliferates, and these produces surfactant, and this also gets differentiated into type 1 pneumocytes, thereby restoring the alveoli epithelium. Fibrotic phase, some patients enter into this phase and may require longer periods of ventilation or supplemental oxygen. In addition to this, there is intimal proliferation, which can lead to pulmonary hypertension. These patients can also develop emphysema and large bulla, the rupture of which can result in pneumothorax. This is the criteria to diagnose ARDS. PaO2 by FiO2 should be less than 300. It is 300 to 200, it is mild. 200 to 100, it is moderate. Less than 100, it is severe. All these values should be taken with a PEEP of 5 centimeter of water. This is also called as the Berlin's criteria. Berlin, B-E-R-L-I-N, Berlin's criteria. Management mostly supportive. Prophylaxis against DVT because the patient will be bedridden, and GA ulcers, etc. has to be given. And mechanical ventilation with the tidal volume of 6 ml per kg rather than the 12 ml per kg which is routinely used will be more beneficial and protects the lung from valve trauma. And positive end expiratory pressure can be given to prevent atelic trauma. That is, this positive end expiratory pressure will prevent the alveoli from collapse at the end of expiration. Some studies have shown that prone position ventilation offers mortality benefit. Apart from this, fluid restriction and diuretics to lower the left atrial pressure has to be done, and sedation and neuromuscular blockade have given positive results. And steroids have no supportive evidence in ARDS, hence it is of no use in ARDS. This is the evidence-based recommendation for ARDS therapy. See that the only treatment that has a Class A recommendation is low tidal volume, that is at 6 ml per kg. None other than this has Class A, only this one, low tidal volume.